السلام عليكم طلابنا الأعزاء، إن شاء الله تكونوا بخير. اليوم محاضرتنا لأورال باثولوجي، المحاضرة الأولى عن biopsy principles and techniques. Introduction. Oral and maxillofacial pathology is the specialty of dentistry and discipline of pathology that address the nature, identification, and management of all diseases affecting the oral and maxillofacial regions. So, it is a part of dentistry and discipline of pathology address the nature, identification, management of disease affecting oral and maxillofacial region. Surgical pathology is the specialty of pathology which deals with the diagnosis of disease by microscopical examination of tissues taken by a surgeon biopsy. Biopsy is the removal of a tissue from a living individual for a diagnosis by histopathological examination. So, removal of tissue from a living individual. Types of biopsy. Classify biopsy according to the following. According to the size of tissue that to be biopsied. Number 1, incisional biopsy. Only a portion of the lesion are sampled, therefore the procedure is strictly for a diagnostic nature. Incisional, only a portion of the lesion. Number 2, excisional biopsy. The entire lesion is removed, usually with a rim of normal tissue, and therefore the procedure is served both a diagnostic and therapeutic function. Excisional, the entire lesion is removed. This is the difference between incisional and excisional, where incisional portion of the lesion are sampled, while excisional the entire lesion is removed. Also, we classified biopsy according to the instrument used to obtain them. Number 1, cautery biopsy. Number 2, cone biopsy. Number 3, core needle biopsy. Number 4, vacuum assisted biopsy. Number 5, endoscopic biopsy. Number 6, sponge biopsy. Number 7, surface biopsy. Number 1, cautery. Of these, the one usually least suitable for microscopic interpretation is that obtained with cautery, because this instrument chars and distorts tissue. So, cautery, the usually least suitable for microscopic interpretation because it instrument chars and distorts tissue. Number 2, cone biopsy, in which remove a piece of tissue which is cylindrical or cone-shaped. From the name cone biopsy, cone-shaped, it performed to diagnose cervical cancer. It often done following a pap smear, colposcopy, and punch biopsy. This is the cautery machine. This picture shows a lesion at the floor of the mouth, with the floor and the tongue. So we need a biopsy to make the definite diagnosis. This picture shows cervical cancer diagnosis, pap smear, HPV testing, punch biopsy, endocervical curettage, cone biopsy, bleep. Number 3, core needle biopsy or core biopsy is performed by inserting a small hollow needle through the skin and to the organ or abnormality to be investigated. Also often performed with the use of spring-loaded gun to help remove the tissue sample. So in core biopsy we insert a small hollow needle through the skin and into the organ or abnormality to be investigated. Number 4, vacuum assisted biopsy. Core biopsy is sometimes vacuum assisted with a vacuum device. This method enables the removal of multiple samples with only one needle insertion. So vacuum assisted biopsy enables removal of multiple samples with only one needle insertion. We see here core biopsy needle. Multiple samples may be taken. The tissue sample lies within the needle, keeping more structure than on fine needle aspiration. This also shows the picture with the parts, thumb wheel, specimen cassette, cutter knob. Endoscopic biopsy is a very common type of biopsy that is done through an endoscope, which is inserted into the body along with sampling instrument. Oh, it is a very common type of biopsy through endoscope inserted into the body with a sampling instrument. Number 6, punch biopsy typically is used by dermatologists to sample skin rash, moles, and other small masses. Number 7, surface biopsy involves sampling or scraping the surface of a sore or tumor to remove cells for pathological testing. So in surface biopsy, sampling or scraping the surface of sore or tumor remove cells for pathological testing. So this picture we see endoscope from the esophagus to the stomach. So we saw gastro endoscopy or upper endoscopy. This what we see, punch biopsy. Done usually used by dermatologists, sample skin rash, moles, or other small masses. This is different skin lesions. Now some general rules for the biopsy procedure. Number 1, the larger the lesion, the more the numerous the biopsies that should be taken it. Wherever the lesion is large, the more numerous biopsy we must take from it. Number 2, in ulcerated tumors, biopsy of the central ulcerated area may show only necrosis and inflammation, The most informative biopsy is likely to be one taken from the periphery that includes both normal and diseased tissue. So, in ulcerated tumor, not take only from the central, which show necrosis and inflammation. The most informative, we must take from the periphery, which include the normal and diseased tissue. Number three, the biopsy should be deep enough that the relationship between tumor and stroma can be properly assessed. Depth of the biopsy should be enough, so the relation between tumor and stroma should be assessed. Number four, deeply seated lesions are sometimes accompanied by a prominent tissue reaction, which may be characterized by chronic inflammation, hyperemia, fibrosis, calcification, and metaplastic bone formation. If the biopsy is too peripheral, this may be the only tissue obtained. Number five, when several fragments are obtained, they should be all be sent to the pathology department and all of them submitted for microscopic examination. When we take several fragments obtained, must be sent for pathology for microscopic examination. Number six, crushing or squeezing of the tissue with forceps at the time of performance of the biopsy by the surgeon, at the time of gross examination pathology, or at the time of imaging by the histotechnologist should be carefully avoided. So crushing and squeezing of the tissue should be avoided. Number seven, once the biopsy is obtained, it should be placed immediately into a container with an adequate volume of fixative. When we take biopsy, immediately we should place it into a container with adequate volume of fixative. Number eight, depending on the presumed or known nature of the lesion, consideration should be given at the time of the biopsy to the possible need for special studies such as touch preparations, electron cytogenetics, molecular genetics, flow cytometry, or others. So technical points to be considered by the surgeon in a biopsy procedure. Number one, do not paint the surface of the area to be biopsied with iodine or a highly colored antiseptic. Number two, local anesthesia should not be injected directly to the lesion but around the peripheries. Local anesthesia not injected directly to the lesion but around the peripheries. Number three, use a sharp scalpel to avoid tearing tissue. The scalpel should be sharp. Number four, use care not to mutilation the specimen when holding it with forceps. Number five, remove a border of normal tissue if possible. Number six, fix immediately with 10% buffered formalin or 70% alcohol. Number seven, put landmarks on tissue to indicate, for example, sutures. Number eight, labeling by a name. Now, indication for biopsy. Number one, any lesion that persists for more than 2 weeks with no apparent etiologic basis. More than 2 weeks with no apparent etiologic basis should be biopsied. Number two, any inflammatory lesion that does not respond to local treatment after 10 to 14 days. Number three, persistent hyperkeratotic changes in surface tissue. Number four, any persistent tumescence, either visible or palpable beneath a relatively normal tissue. Number 5, inflammatory changes of unknown cause that persist for long periods. Number 6, lesion that interfere with local function. Number 7, bone lesion that not specifically identified by clinical or radiographic finding. Number 8, any lesion that has the characteristics of malignancy. Number 9, erythroplasia. Lesion is totally red or has speckled red appearance. Number 10, ulceration lesion is ulcerated or present as an ulcer persists for more than 2 weeks. Number 11, growth rate exhibits rapid growth. Number 12, bleeding lesion leads on gentle manipulation. Number 13, duration lesion and surrounding tissue is firm to the touch. Number 14, fixation lesion feels attached to adjacent structures. Now, diagnostic cytology. Diagnostic cytology, when performed by well-trained, experienced individuals, offers an extremely high degree of reliability. A positive cytological diagnosis of malignancy under these circumstances should be given the same weight as one obtained from a surgical biopsy. The cytologist will make a certain number of false negative diagnoses depending on the source of material, but false positive diagnoses should practically never occur, for they will in themselves invalidate the method. Fine needle aspiration (FNA) was developed at Memorial Hospital in New York City in the 1920 century. It is generally carried out with a fine needle, OD 0.6 to 0.9 mm. Some under image guidance, it has contributed a great deal to transform cytology from primarily screening tool to a powerful diagnostic techniques. Now, what we see, fine needle aspiration under ultrasound on this thyroid, this nodule, this needle inserted into the nodule with the ultrasound guidance. Abrasive cytology, exfoliated cytology. This method has provided very accurate results over the years for symptomatic patients, as good as done with the use of eucalyptic agents or abrasive methods. This rather involved procedure precludes its use as a general screening method for unselected patients. Furthermore, even high-risk patients, such as those with pernicious anemia or low hydrochloric acid levels, the results of screening tests have been disappointing. This is what we see, exfoliative cytology. Number 1, cytology is not a substitute but an adjunct to the surgical biopsy. Number 2, it is a quick, simple and bloodless procedure. Number 3, it helps as a check against false negative biopsies. Number 4, it is especially helpful in the following up detection of recurrent carcinoma in previously treated cases. Number 5, it is valuable for screening lesions whose gross appearance is just that biopsy is not warranted. Laboratory testing in histopathology. Number one, fixation. Of the many fixatives that have been proposed, 10% buffer formalin remains the best compromise under most circumstances. It is inexpensive. The tissue remains in it for prolonged periods without deterioration, and is compatible with the most special stains, including immunohistochemical techniques, as long as the tissue is placed in fixative shortly, less than 30 minutes after surgical removal, and overfixation more than 24 to 48 is avoided. Also, there is other solutions like Zinker fluid, bones fixative, also carnoy fixative, 70% ethanol. Number two, laboratory tissue processing. These refer to any treatment of tissues necessary to impregnate them with a solid medium to facilitate the production of sections for microscopy, labeling of tissue, completion of fixation process, gentle and complete dehydration to remove aqueous fixative and any tissue water, for example ethanol and alcohol. Clearing the substance which is totally miscible with both the dehydration agent which precedes it and embedding embedding agent which follows it, for example xylene. Embedding, for example wax resins with and agar. Microtomy is sectioning of tissue blocks by microtome, staining either by ordinary stains, hypotoxin and iodine, or special stains. Special stains, the most commonly used at present are the following: periodic acid skip stain, stains for microorganisms, argyrophene and argyrophilic stains, amyloid stains, reticulin stains, trichrome stain, phosphotangistic acid hematoxylin stain, stains for hemospleen, pearls, melanin, fontan mason, and calcium boncosa, stain for neutral lipids, mucin stains. Now, immunohistochemistry, the most important diagnostic application of immunohistochemical markers that have been applied widely to surgical pathology problems, whether the diagnostic is prognostic or predictive indicators, or as histogenetic probe, are listed as follows: actine, albumin, P53S 100 protein, desmin, CD34, Q, bend 10, epidermal growth factor receptor, Surgical pathology report. The usual surgical pathology report is composed of five major fields. The first, which follows the demographic formation, is designated as history and contains the essential clinical data known to the pathologist at the time he dictates a description of the gross specimen, such as sex and age of the patient, symptoms, surgical finding, and types of surgery. The second field, designed as gross, contains the gross description of the specimens. The third field is termed microscopic. We regard this an optional feature of the report, which in many cases is unnecessary. The fourth field and most important field of the report is the diagnosis. The fifth field, which is optional as a note or comment. If a frozen section has been performed, the information regarding the organ biopsy, the diagnosis given, the names of the pathologists who performed the procedure, and the final diagnosis corresponds to the frozen sample should be included in the report, either as separate field, which we prefer, or incorporated into the history or gross fields. Thank you for listening.